Good evening and welcome. We're all very pleased to have you here this evening, and thanks for being here. It's going to be a great conversation on how heart disease really uniquely affects women. You know, there's been a misconception that heart disease predominantly affects men, yet it remains the leading cause of death for women. You know, symptoms feel different. Our risk factors can be different. And sometimes our concerns can be misunderstood or overlooked. And so that's why tonight is about increasing your awareness and giving you the tools so that you can take charge of your cardiac health. We're pleased to have, I have to say, really 3 outstanding cardiologists with us this evening. They've all put a lot of thought into tonight's session with the intention that it is informative, that it's relevant, and that it gives you, it's practical and informative, but it's more so designed so that you leave feeling empowered to take charge of your own cardiac health. So I am pleased to introduce, and they'll be coming up as they speak, but our first cardiologist is Dr. Natasha Cuk. She is a cardiac electrophysiologist with Memorial Cardiology Medical Group. Dr. Christina Rodriguez Ruiz, Medical Director of Advanced Cardiac Imaging with the MemorialCare Heart Vascular Institute at Long Beach Memorial. And last is Dr. Nissi Suppogu, who is Medical Director of the Women's Heart Center at the MemorialCare Heart Vascular Institute at Long Beach Medical Center. We'll save time for questions at the end. Definitely they will be asked. For those in the room, we'll have a microphone that we'll take around so that you can ask them directly. And for those who are our virtual guests, please type them into the chat area and then we will read them for the group. And so with that, please join me in welcoming our first presenter, Dr. Nissi Suppogu. Thank you.
Hello. Good evening, everybody. Thank you for being here this evening. Some faces that I recognize here in the audience, and some new ones. And there's always something new to learn, some new question to ask, right? So I'm going to be talking about, the objectives for my talk today are, what is a heart attack? Recognizing chest pain, understanding your risk for heart disease, when to get tested for heart disease, and how to prevent heart attacks. I don't know where I should position myself, but I hope this is okay. All right. So before going into what is a heart attack, these are very important facts about heart disease, the current state. So heart disease is the leading cause of death for both men, women, and people of most racial and ethnic groups. 1 person dies every 34 seconds from cardiovascular disease. In 2023 alone, there was 919,032 people that died from cardiovascular disease. That's equivalent of 1 in every 3 deaths is from cardiovascular disease causes. Heart disease costs about $417 billion from 2020 to 2021. And this includes not just the cost of healthcare services, medications, but also loss of productivity due to death as well and quality of life. So what is a heart attack? A heart attack happens when the flow of blood to the muscle of the heart is severely reduced or completely blocked off. This can happen with fatty cholesterol buildup in the wall of the blood vessel into the lumen of the blood vessel. So you can see here that there is plaque buildup and it ruptures and a clot forms on top of it. So it decreases the flow of the blood to the muscle, and that's what causes a heart attack. And the plaque can grow. Here's another diagram to show that, I'm sorry, I think the format of my slides was changed a little bit, so I apologize. So here's another cartoon or an animation of how a heart attack happens. So we develop plaque in our blood vessels, and the blood is flowing, okay, until the plaque gets to be more than about 70% when we actually start to have symptoms. Or the plaque can be less than 70% too, and rupture at some point, and form a clot on top of it, and acutely stop all the blood that's flowing to the muscle of the heart. So that's how a heart attack is caused. But can heart attacks happen without blocked arteries? Yes. Heart attacks can absolutely happen without blocked arteries. Especially about 50% of women presenting with chest pain or chest pain-like symptoms to the ER for evaluation end up having no obstructive coronary artery disease, which means there's no blockages in the blood vessels of the heart, and they can have microvascular disease, the tiny blood vessels here that don't appropriately allow for the flow to increase to the muscle. Or they can have spasm of the artery without any plaque that's built up in the blood vessels. Or they can have rupture or tear of the membrane of the blood vessel into the lumen, causing an occlusion. Sometimes the microvascular disease under significant amount of stress can cause a broken heart syndrome, where a segment of the heart becomes akinetic or doesn't move good enough. And sometimes there's inflammation of the heart muscle because of infections, or it can be because of small vessel disease as well, or autoimmune diseases. So absolutely, heart diseases can happen without blocked arteries. So it is very important to recognize chest pain, or like most women don't always experience chest pain, or rather they do, but they describe it differently. So that's why it's become so popular that women have different symptoms. It's not that we have different symptoms, it's just that we perceive things clearly, we describe things clearly, just because we go through from menarche to menopause, so many, through labor and whatnot, right? All the pains that we feel. So chest pain in women can also feel like a heartburn-like feeling. They can feel significant amount of fatigue associated with the discomfort in their chest, or feel like they're going to faint with dizziness. They can have nausea and vomiting associated with the chest pain, or pressure or tightness symptoms. They can also break into a cold sweat or have like profuse sweating after an episode of chest discomfort. Usually, chest pain related to the heart is within this area that's highlighted in the body, but it can be associated with shortness of breath, dizziness, unusual fatigue, and it can be two types. There's stable chest pain, which occurs with exertion, with stress, so there's a pattern to the way that chest pain occurs that's usually stable. Then there's unstable chest pain that has no pattern to it and can happen anytime and can be profound too. So when do we not worry about chest pain? So not all chest pains cause heart attacks, right? But it is heart attack that kills people. So it's very important to identify when to worry and when not to worry. So when chest pain or discomfort is momentary, lasting for a few seconds at a time, feels like a pricking sensation in a small area where you can say, hey, right here, I can touch myself and feel it, or show it to me with the finger pointing to your chest, can be reproduced when you press on it, or, oh, it gets worse when I move my arm, or when I bend down, that's the only time I feel it, and it goes away in a few seconds, gets better with breathing or positional changes, or it goes below the abdomen into your legs. But women are so good at managing different things, so we always, not always, many times we tend to downplay or mask our symptoms and try to offer an explanation for it. Yeah, I'm fatigued because I didn't sleep well last night, or yeah, this is unusual, this discomfort in my chest, or this significant fatigue I'm feeling. But yeah, it was Christmas, I was so busy. And don't try to offer explanations. If you feel that it may be your heart, and if you're feeling like something is profoundly wrong, then ask your doctor, say, think for yourself, is this my heart? And when you do end up in the ER, ask the doctor treating you, could this be a heart attack? Because heart attack is what kills, and that's what is more important to identify. So everybody having chest pain or chest pain-like symptoms, do everybody end up having a heart attack? No. So it's so important to understand what your risk is for heart attack. And American College of Cardiology and American Heart Association have worked day and night with several of us cardiologists over decades to come up with scores and screening policies and whatnot to see what our risk factor is. There is one specific study, the Framingham Heart Study, which most of you may have heard of it. It started in 2013. It started in 1948. That's the first generation that they enrolled. And when they looked at all the people from 1948 to identify common factors or characteristics that contribute to cardiovascular disease following its development over a long period of time in a large group of participants. And these participants, what's important to understand for this score is these participants had not yet developed overt symptoms of cardiovascular disease or suffered a heart attack or stroke. So they haven't had an event. They're just like anybody else without a heart disease or any symptoms for heart disease or didn't need a stent or anything. And they looked at all of them, and they released a score in 2013, which is called the Atherosclerotic Cardiovascular Risk Score, or ASCVD Risk Calculator. That's freely available for anybody online to assess your risk. And so far, the Framingham Heart Study has enrolled 3 generations. So 1948 was the first generation, then they enrolled the second generation in 1971, and the third generation ongoing now since 2002. So ASCVD risk calculator consists of basic things like your age, sex, race, systolic blood pressure, diastolic blood pressure, cholesterol, types of cholesterol, good and bad, history of diabetes, whether you're a smoker, hypertension, whether you're on treatment for your cholesterol, whether you're taking aspirin therapy or not, and they can also recalculate it from a previous score that you would have calculated. So it has basic things. But we know now that there's a lot of enhancers, risk enhancers, some that are more specific to women, like pregnancy-related issues with the pregnancy-related preeclampsia, hypertension, preterm delivery, or it can be conditions that women are disproportionately affected with, like autoimmune conditions, rheumatoid arthritis, lupus, stress and anxiety even. So in 2028, they came up with an update to add those risk enhancers. So even if your risk is lower in the ASCVD risk calculator, if you have the risk enhancers, then it increases your risk for developing coronary artery disease. And the ASCVD risk calculator gives you a risk score for 10 years. Like, what's your risk in 10 years? So, but there's a lot of young people ending up with cardiovascular disease and having more questions. So then, more recently, AHA/ACC came up with the PREVENT score, which gives us not just a 10-year score, but a 30-year score for total coronary cardiovascular disease, including the ASCVD and heart failure. So they compared the PREVENT score with the ASCVD risk score, and they saw that PREVENT score correlated more closely with the observed events than the ASCVD risk score, and it also gives a 30-year risk, not just like a 10-year risk. So we have good risk estimators or screeners, sort of, to help us understand what our risk for heart disease is. And it's very important every time, being a women's heart director and women's heart specialist, for us to understand that women have specific risk factors through their phase of life, through menarche, PCOS, being on OCPs, preterm menopause, pregnancy-related issues, and menopause itself and the transition after that. It's important to understand what menopause does physiologically. Menopause does not cause heart disease, but it does accelerate our risk factors and comorbid conditions to a state where it can accelerate heart disease. So menopause can cause a thickness of the blood vessel wall. It can cause gaining of weight right in the middle there, the visceral and adipose tissue going up, changes with the cholesterol, with the LDL, ApoB protein, and changes in HDL, increases the fat mass, lean mass. So all these are physiological changes that happen with menopause. So it's important to be aware of that. And also to know that heart disease rises steeply after menopause. So beyond the age of 50, 60, so you see between 55 and 60 is where it starts to take the turn, and it rises up steeply with aging. So there's a lot of talk about calcium score now. Everybody wants a calcium score. What's my calcium score? And why is it important? Does everybody need a calcium score? And is it important? What does the calcium score tell us? So there was a study, this was done in 2023, from the Multinational Confirm Registry, where they compared patients. I don't know if you can differentiate the colors in the graphs, but the yellow line is for patients that have had an event, that have had an atherosclerotic event, meaning that they had a heart attack or they had a stent placed already. And they compared it from patients that had calcium scores without an event. So they've had calcium scoring done, and they looked at those patients and compared them with patients that they already had a risk with. And it was seen that patients that had a calcium score over 300, their events in the next 5 years were similar to patients that had an event previously. So calcium score over 300 and higher puts you at the high risk category. And you can see that it was not just for them having events associated with bad outcomes, but also like they were late revascularizers. They also had heart failure relationship and heart attack, having an acute episode of a heart attack as well. So this graph tells us that if you do get a calcium score, and if you have a high score, the higher the score, the worse the risk, right? But what about if my calcium score is 0, right? This is a slide to show where the calcification is. So that's all the white stuff is the calcium. And then, so what if my score is 0? Do I have no risk? Well, interestingly, women don't tend to calcify their plaque until around menopause and after, unless their risk is higher for heart disease, right? So even if your calcium score is 0, you can still have soft plaque that can give you a heart attack. Think of it like the eggshell analogy, right? Like an egg. If you take a non-boiled, like a raw egg, there's all gooey stuff inside of it with a very thin shell that covers it, right? Think of the soft plaque like that. It's all soft and gooey on the inside and a very thin shell covering it. And if we don't identify your risk at that point and start you on the appropriate therapy, say for example a statin to prevent your progression of your disease, and change it into a hard-boiled egg with a harder shell to prevent it from leaking out and causing a blockage and a heart attack, okay? So even if your calcium score is 0, that's why we never say, when patients come to us and we check them out and their calcium score is 0 and risk is low for heart disease, we say your risk is low. We don't say your risk is 0 for heart disease, and that's very important to understand. So what to do with the risk information? So now we know that, you're a low risk, borderline risk if you're 5 to less than 7.5, if you're greater than 7.5 to less than 20, or greater than 20. So greater than 20% is the highest risk. That indicates that you need to be on an aspirin and statin for sure. In between here is a discussion, statin for sure, but a discussion about whether you have the risk enhancers that we spoke about earlier, and see if you need to be on an aspirin or not. And if it's low, then, lifestyle modification. But lifestyle modification is for everybody, whatever your risk score may be, right? And when we know the risk score, if you're a low risk, moderate, or high risk, then it helps us to understand what test is good for you. What test can we do to identify what's going on that's causing your symptoms, or because you're a high risk, what can I do as your cardiologist to sort of freeze that risk and not let it progress, right? So if you're a patient coming to the ER, the emergency room, with acute chest pain, having EKG changes and a troponin elevation in the blood, then okay, you need an invasive testing with a cardiac cath to see if you have blockages or not. But if you're a patient that's having either stable chest pain, like we discussed earlier, or maybe milder version of some discomfort that's been going on, and you need to find out what tests to be done, then it's important to understand what your symptoms are. If you're asymptomatic and low risk, really nothing much to do. But if you're low risk and you want to proactively contribute to your health, then it's important to know your risk. And if you're symptomatic, do we need to do a stress test? Like, do I need to put you on a treadmill with an echo? Do I need to send you for a nuclear stress test to find out if you have any ischemia, like lack of blood supply to the muscle of the heart? Or do you need to get a coronary CTA to see what the amount of stenosis is, whether the blockage is more than 70% and concerning, or less than 70% and needs medical management, or there's soft plaque and other things that go on, right? So all of the risk stratification helps us to identify what test we can do and how we can freeze the risk and work on decreasing it going forward, right? But like I said initially, women tend to have smaller blood vessels, tend to calcify their plaque later on, tend to present with chest pain symptoms to the doctors, and have all the testing that we spoke about now, and are told that everything is fine, there's nothing wrong with your heart. But we also saw earlier how women can have smaller blood vessels that are affected and can have microvascular disease or vasospasm, right? So then what kind of testing do we do for women like that? So for women, for testing for chest pain with no obstructive disease, so if you're a female patient having discomfort in your chest, or shortness of breath with activity or without activity, you're just watching TV and you're feeling the sensation of discomfort, like something's going on, and you already saw your doctor, primary care, they already sent you to a cardiologist, you already had a testing, a stress test or a nuclear stress or a coronary CT scan, and everything looked okay. You had zero plaque, or you had no obstruction, or you have some plaque not explaining what's happening, then we need to go look for microvascular disease. It is as important as the bigger blood vessels that have blockages. So the specific testing that we use here is a non-invasive testing and invasive testing. Invasive testing is a gold standard. It's called the coronary functional testing, where it's an angiogram, but we use two kinds of medicines called adenosine and acetylcholine to see what the response of your tiny blood vessels are and the smooth muscle of the blood vessel is to the medication, to identify what sort of small vessel disease you have. Or we have non-invasive testing, which is a cardiac PET scan, which helps us to assess what the flow through the muscle of the heart is and establish the microvascular abnormality in the heart. Or we have stress cardiac MRI, which also does similar things like the cardiac PET MRI and helps us to understand what the microvascular abnormality is. Now, the invasive testing has an advantage of giving all the various pathways that are abnormal for the microvascular, including spasm, versus the non-invasive only give us the microvascular abnormality. And I am so blessed to be working at Long Beach Memorial Hospital because I get to work with fabulous colleagues like Dr. Rodriguez and Dr. Cuk. Dr. Rodriguez is an imaging specialist, not just a cardiologist, but an imaging specialist, and she reads all our coronary CTs and help us to understand the plaque. But with her help and her team, we're also going to soon provide this stress cardiac MRI at Memorial, and we're very excited for it because we'll be the only place that's going to be doing this in this area. And also a special shout out to Dr. Cuk, because she's going to talk about atrial fibrillation. I didn't mention much about it, but I send so many of my patients, and they're so pleased to have a female cardiologist who's an electrophysiologist that specializes in rhythm abnormalities, because 1 in 4 postmenopausal women will develop atrial fibrillation as well. Okay, but that's a talk for another day. But and before I close my talk, I want you to focus on what can you do to prevent heart disease, right? Let's focus on prevention. Don't be like, oh, I missed out on all the calcium scores. I should have done it 40 years ago, 30 years ago. No. What can we do to prevent? So the American Heart Association has given us the Life's Essential 8. Just 8 simple lifestyle management changes for better cardiovascular health down the line. And before I just mention each of that, the AHA has just released a statement, a scientific statement. I think it's just pretty fresh, like it came out this week or last week, where they predicted the cardiovascular outcomes in women next 25 years. Like in 2050, what's a heart disease risk, what's hypertension, diabetes, obesity, stress, etc. How is it going to be? And it's really, I was really disappointed with the findings because there is overall increase in cardiovascular outcomes. And 3 main things that were most highly elevated were obesity, hypertension, and diabetes. So we still have a lot of work to do, and also in socioeconomically deprived areas as well. And I think a lot of work. If you're healthy, great, go educate 10 other people. If you're not, focus on your health. Bring 10 others that are not well to work with you together, right? But if you're a female patient with symptoms or questions, please get checked. Please focus on Life's Essential 8. So eat better, get active, focus on diabetic numbers, weigh yourself. A healthy weight is important. Low cholesterol, having an LDL less than 100 for primary prevention is important. Normal blood pressure, less than 130 over 80, not 135, not 85, not 140 over 80. No, less than 130, less than 80. That's the blood pressure we're looking for. Don't smoke. Smoking is bad. Sleep better, at least 7 hours of sleep at night. All these tend to help with decreasing the bad outcomes from heart disease. If you have it, it decreases it. If you don't have it, it prevents it from coming on. And that's it. Thank you.
Okay. So, hi everybody. Thank you for being here. I see some of my patients, so I get excited. Is it okay if I stand over here? Okay. Okay, cool. So basically, Nissi gave me a great introduction. So I am a cardiologist. I focus on prevention, but I am an expert in cardiac imaging, and that's what we're going to kind of talk about today, okay? Forward. Okay. So you might ask yourself, as a cardiologist, why did I choose cardiac imaging? And basically, I just wanted to kind of be the Sherlock Holmes of the group. So I want to see what nobody else sees, and then help you guys and gals find out what's going on more specifically and individualize your care further. So that's kind of why I decided to do cardiac imaging. And in this talk, we're going to be talking about coronary CTA and also cardiac MRI. Are you guys familiar with those modalities? No? I see some no's. Okay, so Nissi talked about calcium scoring. It's similar to that, so okay. A lot to learn then. So basically, this is what I mean when I say I wanted to see more. This is a CT scan of the heart with contrast. And the contrast you see going through the artery here, and you see these calcified plaques in white, and therefore I can see the plaque there and tell you, okay, you have this level of stenosis, this amount of plaque, and this is your specified risk, right? Oh, they added this. But yeah, this is the 3D version of the CT scan. So when we get a CT scan that's CTA, we have the privilege of seeing your heart in a 3D version. So we get to rotate it, I get to show you all your arteries, and I think my patients know if we do this study, I pull it up in my clinic and show it to them. So that's pretty cool too. So we'll start with a case presentation. This is a 50-year-old male. He has HIV, high cholesterol, and a family history of premature coronary artery disease. So what that means is that one of your parents had a heart attack either in their 40s or their 50s. So that raises an alarm to all of us to be, okay, that person is at a higher risk to having a heart attack sooner, okay? And so here we have some cholesterol numbers. I'm sure you're all familiar with this. Total cholesterol, 191. The LDL cholesterol, which is considered the bad cholesterol, is 110, which is supposed to be less than 100. The HDL is okay at 45. And then we do other testing, such as lipoprotein little a. I'm sure I've sent that to some of you. It estimates our genetic risk, okay? And then this high sensitivity CRP, which is at 1, which is not elevated at all. That's how we kind of estimate your inflammation. And so for this specific patient, Nissi mentioned the ASCVD score is 7.2. We learned the ASCVD score. For this patient, it's 7.2. So what do you think? This is low risk, intermediate risk, high risk? What do you guys think? Low, right? Somebody said low, nice. Okay, paying attention, good job. Okay, so low risk. So for this patient, even though they have HIV and they have their family history, we're calculating a low risk. Okay, so why is that important? I have a little bit of a suspicion as a cardiologist. I'm like, okay, the patient is asymptomatic, but they have all these other risk factors. I'm gonna go ahead and order a calcium score, which Nissi already explained what that was. And so she already kind of went through the ASCVD score, so I'll go through this really quick. Basically, it's a population-based score. So we take a bunch of patients, we kind of see what they're gonna have in the future, and then we calculate a score based on that. And the problem with that is it might overestimate risk. So we wanna do other testing, like the calcium score. And also, I wanted to mention, for example, in this graph here, for diabetic patients, for them to get more than 7.5 prediction of risk, they have to hit almost like a 55 age range, if you see it right here. Maybe not in the back, because I really didn't see in the back too well. But basically what this is saying, the take-home message is, if you're a young patient coming into my clinic and I calculate the score, I might not be catching your risk, okay? And so therefore, I have to think a little bit harder about what to do with you and what testing to do. So that's very important. Let's see here. Okay, and so Nissi mentioned this, Dr. Suppogu. So usually when we screen patients, we're looking for a couple things. When we're stress testing a person, we're looking for if the patient has a certain amount of blockage, Nissi mentioned more than 70%, or if they have ischemia, which is basically when a patient doesn't have enough oxygen flowing through their heart. And how we do that is stress testing. But the problem is that we might not catch those patients soon enough, because guess what? 60 to 75% of heart attacks happen on patients that don't have more than 70% blockage. So we have to kind of think further, look at your risk, and test further, okay? So the calcium score, you already know, you guys are experts. It's a CT scan, no contrast. And it's great when it's 0. But what happens when it's not, right? I put this little iceberg analogy. So you can see we might be catching the calcified plaque, but we might not be catching that fibrotic plaque, that soft, mushy plaque that Dr. Suppogu mentioned. And so because of that, if a patient has a calcium score of 0, sure, you can buy yourself 4 to 5 years of not having extra testing or no statins, but then we have to think about what are your extra risk factors. And for that, there's the coronary CTA. I already showed you pictures about it in the beginning, but you can see here illustrated that there's calcium here, but you can't see the soft, mushy plaque. The soft, mushy plaque you can see right here in the coronary CTA really clearly, these yellow lines, and then that shows me, okay, does this patient have a lot of mushy plaque? Do I have to reduce it? And all that stuff. I had some other stuff here, but I guess they took it out. That's fine. Basically, what I wanted to say is this is a great test for symptomatic patients. It's very sensitive, meaning I'll catch it, I'll see the anatomy of your vessels, and also it's great to rule out obstructive disease. So it has a very high negative predictive value, and that's really good, right? So in CT, there's also other cool things I can see. Not only soft, mushy plaque, I can see sort of if the mushy plaque has some characteristics that might put you at risk for a heart attack in the future. And these are these high-risk plaque features right here. It's low attenuation plaque, which I measure in the CT scanner, napkin rinsing, and spotty calcification. All these things I kind of mention in my report. If you have it, then we have to kind of take care of you a little bit more. And coronary CTA has come a long way, right? We have the anatomical testing that I showed you, but we also have a way to measure flow through the vessels, which is this illustration here. With AI kind of technology, we can see if this narrowing that we're seeing is significant. And obviously red here means bad, just in case. But there's also now a new kind of feature that we're using for coronary CTA, which is this plaque analysis feature here. And basically, it is what it says. It's just an AI feature that analyzes the plaque inside of your coronary artery, and not only do I have to describe it, but it says the amount of soft, mushy plaque that you might have, basically. Okay, so here's an example of how that looks like. And by the way, we're gonna have this at Long Beach Memorial soon, I think come April, so I'm very excited. And so we look at the whole vessel here. It's very, illustrative, I think, for all of you. The more yellow the plaque is, the softer and mushier it is, let's say it like that, okay? And if you have some features that are blue, then the more calcified the plaque is. And at the end of the report, we'll get a total of that mushy plaque and a total of that calcified plaque. And that will definitely help us individualize care. And so I think Dr. Suppogu mentioned this as well, that we want the plaque to be hard as a shell. So the harder the shell, the lower your risk of it rupturing, basically. And actually, that's what we do with statins, okay? We give you statins to lower inflammation, to lower the amount of soft plaque, and try to convert it into calcified plaque, hopefully. And so this is what we're looking for when we're seeing a CT scan, basically. And so back to our patient, we did the calcium score, right? Patient came back with a calcium score of 112, which is a moderate calcific plaque burden. He's in the 90th percentile, which means that for this patient's age and ethnicity, he's at a higher risk than his peers, basically, okay? So the question remains, am I providing this patient adequate risk with telling him, hey, yeah, you have a calcium score, you're asymptomatic, can I go to sleep, just putting on a statin on him? Answer is no. So basically, I want to know more for him with this new technology because of these risk factors, right? Anything inflammatory, the risk enhancers that Dr. Suppogu talked about, are important for us to consider. So I order the coronary CTA, the FFR, and plaque analysis. And what do we find? Let's see. Okay, so this is his results right here. Over here we have the 3 vessels and the anatomy that we're seeing with the coronary CTA. We can see that there's contrast flowing through the vessel, so it's not severely obstructed. And the flow is all in blue, so good flow, meaning no ischemia. But the plaque analysis tells us a different story here that we have to be a little bit aware for this 50-year-old. So we're finding that this patient has a lot of non-calcified plaque or mushy plaque. So much so that it's like about an 89% of his total, meaning that that's plaque that is very susceptible probably to rupturing and causing a heart attack. So, yeah, I know, it's really cool. So what I'll do as his cardiologist is I'm gonna be very aggressive with lowering his cholesterol by adding probably a high-intensity statin, a PCSK9 inhibitor, which I'm sure some of you are familiar with that one. If not, we'll talk about it later. And then low-dose colchicine. Sometimes we can use it too to reduce the inflammation for this patient. And hopefully, in the future, what I would do is repeat this study and see if the plaque is calcifying. And then I'm kind of making sure that he's okay. Does that make sense? Nice. So this has not been validated, I want to state that, but it's kind of a guidebook for us. If we see this total plaque based on this new technology, and we can guide you guys to be like, okay, our goal is going to be less than 55, the LDL cholesterol, if you have really severe plaque burden. And we can consider all these other management strategies. So basically, it's it's a really good way to kind of guide us further into your care. Let's see. And just to end, not the coronary part, the coronary CTA part, this is kind of an illustration showing that first we considered the clinical factors, the CTA, then we were like, okay, stenosis, plaque, but I think we're gonna be able to do a lot in the future and individualized care once we get all these radionomic, genetic scores and all that and put it all together for an individual patient. Let's see. Okay, so second part of the talk. Cardiac MRI is a very cool technology. Have you had an MRI before? Knee MRI? No? Basically, it's a big donut like this. It takes some time to take pictures, but that might be a bit claustrophobic, but bear with us. The cool thing about it, it has no radiation. The reason is because you're put in this big magnet. It pulls all your protons towards one side, and then we kind of can take pictures that way. So no radiation is good. The protons. Basically, we're all made of a lot of water, so that's why the magnet works the way it works. And so why do we use cardiac MRI? What is this thing that I'm putting myself through? So this is a sonogram of your heart, an echocardiogram. Many of you have had this, I'm sure. Sometimes we can't get good pictures, and sometimes we need better pictures. See this? Much better, right? So the resolution is so good, we can get an accurate evaluation of your ejection fraction. So that's one thing we can do, but we have other things. Let's see here, So we can evaluate your valves. We can do the stress cardiac MRI that Dr. Suppogu mentioned. We can see if there's any scar inside of your heart. If you had a heart attack, I can see if that's, dead heart or alive heart. Cardiac masses and your heart function. So here's that other illustration showing the function of your heart. This is the left ventricle. See how well it's squeezing? That's normal function. This is another illustration of how we measure valve issues. This is a mass inside of the heart right there, which we can clearly see with cardiac MRI. This is scar. This white stuff right here that you guys can see. That's dead myocardium, dead heart. So I can see that too. And I'll show you better pictures of this, but basically we do the stress testing and we can see if there's lack of blood flow. This little black spot right here is lack of blood flow in that spot and can tell us if you have a big obstruction there. And for women, this is kind of cool because sometimes we can't determine if you had a heart attack and no coronary disease. We can't tell if, what's the cause. So a cardiac MRI can sometimes help us diagnose acute myocarditis, which you may have heard from COVID, perhaps. Yes, the athletes falling, yeah, all that. So acute myocarditis was that diagnosis of inflammation inside of the heart. And one of the diagnostic modalities that we use is cardiac MRI to diagnose it. So also we can diagnose or help diagnose congenital anomalies and also genetic diseases, such as hypertrophic cardiomyopathy. And this was a really, this is a live case from the hospital. She was 25 and we caught a genetic cardiomyopathy called arrhythmogenic cardiomyopathy, so that was a good catch. And so in our institution, not only are we gonna do plaque analysis soon, we're gonna be doing cardiac MRI stress testing, which is we inject you with some contrast and we can see if there's lack of perfusion inside of your heart, and that can let us know if you have obstructions in your arteries. And not only that, but we can also determine if you have microvascular dysfunction, which was the little branch disease, basically, what Dr. Suppogu described, okay? So this patient didn't have any disease, see all the white, all good, but then we did the cardiac MRI, and we found that this was really low. I know those values you won't know, but it's very low, so that might mean that the patient has microvascular dysfunction. So that's a very good way to kind of go about this. And so that's it for me. This is our order set. We are going to be offering these services soon, so I'm very excited to kind of help my patients individualize their care a little bit further, okay? Well, yeah, the clearly, yeah. Yes, ma'am. What was that? If we're gonna be having clearly, yes. Okay, I think that's it. I'm gonna leave you with Dr. Cuk, okay? Thank you so much.
Good evening. Can you guys hear me? Okay. My name is Dr. Cuk. I'm a cardiac electrophysiologist, and that is a cardiologist who specializes in heart rhythm disorders. I joined the team a little over a year and a half ago, so I'm really excited to be here. The things we'll talk about tonight will be atrial fibrillation. What is it? What's the definition? Prevalence and risk factors, some symptoms that people experience with AFib, how to diagnose this heart rhythm disorder, and the overall impact to your health. We'll go over some treatment strategies, and then finally address a specific treatment strategy as it relates to stroke, the Watchman procedure. So what is AFib? Atrial fibrillation is an irregular heart rhythm that originates in the upper chambers of the heart, and it prevents blood flow from efficiently being pumped throughout the body. It's commonly referred to as AFib or AF, so you might have heard these acronyms before. AFib is actually the most common cardiac arrhythmia that I treat, and it's a growing problem. There's a significant impact to patients' quality of life, and that includes 5 million people with AFib in the United States, and that's estimated to be up to 12 million Americans by 2030. It's also a global epidemic. So 43 million people are impacted globally by atrial fibrillation. So to understand AFib, first we have to understand how the normal pumping system and electrical system of the heart works. Basically, the heart is divided into 4 chambers. There's these upper chambers that collect blood, and then the bottom chambers that help efficiently pump it to the rest of your body. The top chambers are called the atria, and the bottom chambers are called the ventricles. How does the heart then know how to pump? How does that muscle know how to work properly? Well, your heart essentially has a brain. It has an electrical system. And that normal electrical system is governed by this sinoatrial node. It's in the top right chamber of your heart. And it's able to pace your heart all on its own. It has its own pacemaking capabilities and sets the rate. And then we have these superhighways of electricity that move through the top chambers and the bottom chambers in this very organized fashion, such that every beat in the top should coordinate to a beat in the bottom, and then those electrical signals allow all of that muscle to have that coordinated beating pattern as well. Atrial fibrillation is an abnormality in which the top chamber of the heart has all of these crazy fast signals, and so that basically puts that normal sinoatrial node to sleep. And this takes over the beating of the top chamber of the heart and fibrillates. What fibrillation means is just basically disorganized activity. The heart itself, that nice, electrical system, it does have some fail-safes in place. So that middle part of the heart is like a little, gatekeeper to the bottom chambers. And it only lets some of those very fast heart rates through. So the top chambers can go at 300 beats a minute sometimes. Your heart will prevent that from ever happening in the lower chambers, but it will still beat very fast. And that's kind of one of the problems with AFib is the fast, irregular heart rhythm that you experience, because even though the heart has all these redundancies, it's still going to follow that top chamber pattern and then result in that fast, irregular heart rhythm. What are some risk factors for atrial fibrillation? Well, these normally get grouped into things like modifiable risk factors, things you can manage and treat, and then ones that are non-modifiable. So some common non-modifiable ones are things like age or family history. Or heart disease. Now that can be many different things, but things like heart failure, congenital heart disease, things that you're born with. As far as lifestyle factors, things that can be changed or improved, sleep apnea, obesity, alcohol consumption, smoking, sedentary lifestyle, and stress. These can all significantly impact atrial fibrillation risk and burden if you do end up having AFib. But in between, I kind of want to point out that there are many types of sort of semi-modifiable risk factors, things that you cannot change, diagnoses that you would have no matter, how well you lived your life, but things that you can manage with your doctor and make sure that, it puts you at lowest risk for AFib as possible. Those are things like diabetes. You can't always control whether or not you have that diagnosis, but taking really good care of your health and making sure your A1C and your glucose levels are optimal will help prevent AFib and some of the consequences of AFib. Same goes for high blood pressure, major risk factor for AFib, and that's something you can potentially modify with your doctor. I put cholesterol up there as well, but that's also something to suggest that cholesterol and its effects like artery disease are things that can increase your AFib risk. So I point out blood pressure specifically because it's one of the most common AFib risk factors, and it's also something we can do a lot about. It increases your risk for AFib by about 50%. And the reason is this. If you think about your heart as that pumping system with its, pumping superhighways, your blood pressure is essentially the pressure that your heart feels. So if your heart is pumping against lots of high pressure, it's going to start hypertrophying, meaning getting thicker, and scarring and dilating as a result. And then when the pressure backs up, that affects that top chamber of the heart and can result in AFib. Symptoms of AFib vary quite a bit. The classic symptom is irregular rapid fluttering or a pounding heartbeat. However, that's not always the case for everyone. Some people feel just fatigue or shortness of breath or weakness and can't really describe a palpitating or irregular heart. Some people feel chest discomfort or pain, and they could feel like they may be having an event like a heart attack. Other people feel dizziness or even like they may pass out. And what's not listed here, but also common, is not feeling any symptoms at all. So some people actually don't know they're in AFib. And we'll talk a little bit more about, in a minute, how that matters and what symptoms kind of really constitute symptomatic AFib. So how do we diagnose AFib? Well, originally you would have to have symptoms, which we just described is not always the case. Go to your doctor at the time you were having AFib and get a full 12-lead EKG so we could see the heart rhythm and diagnose that irregular heart rhythm. Now we have a lot of tools to help us to diagnose AFib. So on the left I have an Apple Watch, on the right I have what's called an AliveCor cardia monitor. And these are two of the many devices that are out now that are really useful because what they do is they allow you anytime to get an EKG. And that EKG then can demonstrate whether or not you have atrial fibrillation. You don't necessarily have to be in the right place or the right time. And you may wonder whether or not your doctors like these types of tools. Well, I love them. Obviously, I want an EKG all the time whenever I can. So the one on the left, that's an Apple Watch. The one on the right is an AliveCor cardia monitor. That's one where you actually just put your fingers on the device and it records an EKG. They connect to your phone and then you can print out or send a PDF to your doctor. There's also many, now that these have become more common, there's many different ones on the market and they're all very good, very similar. This is what that looks like, what atrial fibrillation looks like on that EKG you might get from the Apple Watch. So what you see is those spikes, they're very irregular. They have no clear pattern to them. And then in between the spikes, it's also kind of an irregular line. It doesn't have clear bumps and organization that we normally see on a nice normal sinus rhythm EKG. So what is the impact of AFib? Outside of symptoms, I mentioned some people don't feel it at all. Why would we care? Well, unfortunately, it increases the risk of some serious consequences. 5 times the risk of stroke, 3 times the risk of heart failure, 2 times the risk of dementia, and 2 times the risk of renal dysfunction or renal failure. So those are quite serious complications from atrial fibrillation. We classify AFib sometimes in a couple different ways, but the most common way that you may hear from your friends, or if you end up having the diagnosis and talking with your doctor, is along this spectrum of paroxysmal to persistent atrial fibrillation. So paroxysmal AFib is the type that basically comes and goes on its own. and it'll terminate on its own without intervention in under 7 days. But the longer you have AFib, unfortunately, the more your heart likes to stay in it. And over time, that can progress where the AFib lasts sometimes longer than 7 days, and sometimes, in some patients, years and years if there's, not identified or there's not a plan to get them back into normal rhythm. What makes AFib different in women? Well, AFib is actually more common in men when it's diagnosed. Unfortunately, the more serious symptoms tend to develop in women. So they also tend to develop less common palpitations and more of the vague, difficult to diagnose symptoms, things like, weakness, dizziness, fatigue, shortness of breath, that could sometimes be attributed to many other causes and not necessarily immediately identified as an arrhythmia. When women have AFib, their stroke risk they're often diagnosed when they're much older and when their stroke risk is higher. So they unfortunately have higher risks of serious disabling strokes. And the thought is that maybe those differences are driven by the greater risk factor in burden when they do get diagnosed. So what can we do about it? What treatments can we offer? So for patients with symptomatic atrial fibrillation, we often slow the heart rate with medications or try to get people in normal rhythm. And we can do that with a combination of a short procedure and heart rhythm medicines or heart rhythm medicines alone. Another option is what's called ablation treatment. And then separately, we try to reduce stroke risk by putting patients on blood thinners. And the reason I separate these out is actually it's very important to consider the treatments for AFib as two separate arms. One is taking care of the heart rhythm, making you feel better, protecting your long-term heart health from the arrhythmia, and the other is preventing stroke. Because even if you're in normal rhythm, when you've had AFib before and you have a high enough stroke risk, you basically always carry that stroke risk, even if we get you back into normal rhythm. So what causes AFib? Well, I wish I had a good explanation, but it's our most common arrhythmia, but it's also our most challenging to treat, and we also know the least about it compared to others. So other arrhythmias, they have discrete mechanisms. If I get inside the heart and map them out, I can just take care of where the problem is, cut off an electrical connection that's the problem, test it, and say this is never coming back. With AFib, it's a little bit different. The most common trigger for AFib is these what's inside what's called the pulmonary veins, and these veins connect blood flow from the lungs back to the back wall of the left side of the heart. And within them, they have this excitable electrical tissue, and that's where we think most of the atrial fibrillation arises from. And we actually know quite a bit more now than we used to because we have treatments that target those veins, and we found that they significantly reduce the risk of AFib coming back. There are also other mechanisms for atrial fibrillation. So on the right here, these are what are called rotors. They're basically just little racetracks that can develop in the scar in the heart, and they start competing and getting faster and faster. And once they take over, kind of like I mentioned, the natural pacemaker of the heart goes to sleep. So that's another thought as to how AFib can happen. But the most common mechanism that we think is ones that lie within these pulmonary veins. So knowing that, we, over the last few decades, have developed and perfected ablation strategies. What is ablation? Ablation just means selectively killing off tissue. And that means to target tissue that's abnormal to let the healthy tissue take over. We know that pulmonary veins are the issue for the most part, so by isolating the pulmonary veins, basically cutting off the communication of electricity from the veins to the rest of the heart, we can cure AFib in up to 90+% of patients who have paroxysmal AFib. We first started doing that with something called radiofrequency ablation, that's basically burning. And then we moved on to more efficient strategies. After a while, we started using something called cryoablation, where we're able to freeze those veins all at once. And then within the last couple years in the US, we've adopted a new ablation strategy called pulsed field ablation. And that's just a different energy delivery method that's a little more efficient than our old strategies, and a little safer, which is nice. So this is actually an electroanatomic map of the heart from the inside. This is what I do during an ablation procedure. So first, what I'll do is I'll take up my catheters, and I basically measure the electricity from the walls themselves. And here, the red basically is unhealthy tissue, the purple is healthy tissue, and all the colors in between are kind of all the different types of health in between. And you can see that it's very disorganized back there. Well, once we get you in normal rhythm and we get those veins isolated, we have a nice organized electrical picture. So these veins isolated, they don't communicate with the rest of the heart, and that back wall is now nice and healthy and purple. That is the goal of the pulmonary vein isolation procedure. So now that we've talked a little bit about managing the heart rhythm, let's talk about stroke risk. 90% of strokes related to AFib arise from this area called the left atrial appendage. That's a little outpouching in that top left chamber of the heart. And the mechanism is such that when the AFib is disorganized in that top chamber, that little outpouching can collect blood. And then that stagnant blood in that ideal environment can become a clot that then travels through the rest of your cardiovascular system and then potentially gets lodged in the brain. How do we know who is at the highest risk for stroke? It involves basically collecting all of the different risk factors you have and putting them together in a calculator. So you can see some of the things we've mentioned: heart disease, heart failure, hypertension, age, diabetes, a prior stroke, vascular disease, and even your gender, your sex category can potentially increase your risk. And once you're at a level of 2 for men or 3 for women, that's where we typically say your risk is about over 2% per year. So it's time to put you on a blood thinner to get that risk back down to closer to normal. 1 in 3 people with AFib, unfortunately, will have a stroke in their lifetime. We already mentioned that most of the strokes arise from that left atrial appendage. And in AFib, as it relates to other stroke-causing conditions, unfortunately, tends to cause the most life-disabling and life-threatening strokes. Here's a picture of the heart from basically the back. This is a transesophageal echocardiogram, and what you're seeing is the top left chamber of the heart, and there's that little outpouching, the appendage. And within it, you can see a clot has formed and is already kind of at risk for breaking off and moving. So that is a really scary picture. Oh, let me see. This one? Yeah, this, okay. It didn't work. Yeah. Okay. So, yeah, you can see the appendage and the clot forming and kind of encroaching into the rest of the chamber. Some common blood thinners that we use, our oldest blood thinner that we've used for many, many years called warfarin Coumadin. And then there are newer blood thinners we use more often, things like Eliquis, Pradaxa, Xarelto. Many people can take blood thinners without issue, but obviously as a side effect of taking blood thinners that thin your blood, you could potentially have bleeding as a result. Unfortunately, the risk of major bleeding per year in some of the trials was around 2 to 3%, and that did result in up to 25% of discontinuation of these, really important medications. So knowing that the left atrial appendage is a problem, some very smart people ended up developing what's called a left atrial appendage occlusion device. And this is a type of device where we can basically get rid of that outpouching and reduce most of the risk of stroke in AFib. This is a procedure, a one-time implant, doesn't need to be replaced, performed in the cath or EP lab. requires general anesthesia, typically only takes about an hour, and is something you can do kind of in a one-day or one-night stay type of procedure. So I like this image because it shows you the access both for the Watchman and our ablation procedures. We do them in a very similar fashion. So we go up through the veins in the groin to get inside the heart. Here they're just showing you the top left chamber of the heart and how the appendage looks and how it can change and vary from person to person based on anatomy. We do what's called a transeptal puncture. So we basically poke a little hole to get from one side to the other. And then we use our wires and catheters to get stable inside the left top chamber. They're going to show you here the different anatomy. We like to, use silly names: broccoli, chicken wing, windsock. And in order, we'll see the image based on transesophageal echocardiography, and then we'll also use the fluoroscopy and shoot contrast to take a good picture of it. And then we use that image to size the device, make sure it's the right choice for this person's anatomy. Here they're showing you the contrast being injected, and then ultimately can deploy the device, and it basically will put that occlusion over the ostium or the entrance of the left atrial appendage. And then it fits nice and snug. We tuck it to make sure it's not going anywhere. And then once it's done, we can kind of unscrew all the tools and take everything out and leave just that plug in there. Over time, so to do this procedure, people need to be on blood thinners for some period of time and use other medicines to help it heal. But once it heals over, then that's a nice smooth surface area. It's very different from the outpouching that is the risk factor for stroke. So this kind of procedure is something indicated for those who can't take medications like blood thinners for the long term, can tolerate them for the short term. People who've had a history of bleeding and anticipate that may become a problem again. People who've never had a bleed but are worried that it could happen and have those risk factors. Those who can take blood thinners but for one reason or another really can't do it regularly. Or those who have lifestyles and occupations which are just not compatible with taking a blood thinner. So this is a team at Long Beach Memorial. There's Dr. Lee, my partner, in the middle there. This was a picture from when they did their 200th implant, and that was really just in 2024. And since then, we've done almost 200 more. Obviously, any medical procedure, ablation, Watchman, there are risks, and they're very individualized to the patient. So something you really, have to go through your proceduralist and your other doctors, like your primary doctor, to make sure it's right for you. So in summary, AFib is the most common heart rhythm disorder in the United States. It can cause a variety of different symptoms from nothing to palpitations that are kind of classic or nonspecific symptoms, fatigue, shortness of breath, exercise intolerance, things that are actually more common in women than in men. If AFib is symptomatic, and if it's asymptomatic, but in many specific cases where it might be advantageous to get you a normal rhythm, medications and or ablation are good options to do that. AFib increases your stroke risk, and blood thinners are essential for getting that stroke risk back down to normal. Watchman is a potential procedural alternative if you can't take blood thinners. Thank you so much.
Let's give them a big hand. Anyone feeling a little more knowledgeable on this? Yeah, there was some really good stuff. So we are going to go through now, and this is your time to ask questions based on all the information that you heard from our speakers. For those who are virtual, please just tap them in, and we will read them through for the group. And then here in the room, just raise your hand, and I'll run over, and we'll get going. I just want to ask one question here. Let's start at the basics. Should we avoid butter? And what about G? Because we just got some new food guidelines, so we just want to make sure that butter or G, G-H.
Clarified butter, Indian butter.
Okay.
Yeah, both are saturated fatty acids. Both have a lot of saturated fatty acids in them. So olive oil, avocado oil, think of good oils, good trans fats, that's important. So if you can avoid saturated fatty acids, yeah, definitely.
Okay. Then we got a question. What about how many years can you have high cholesterol before you can develop plaque buildup that can trigger a heart attack?
That's a great question. Whoever's going to find that is going to be save all those $480 billion. I don't think, I'll go first and you guys can add on. I don't think it matters how long that your cholesterol is high, because you can have less than 70% of stenosis in the blood vessel and it can rupture and cause a heart attack, right? So it doesn't have to be 10 years of high cholesterol, 4 years of high cholesterol. It can be the first time you see your cardiologist or your primary care and you have symptoms that are concerning and have a little bit of plaque already. And sometimes it's inheritable risk too. So there are some family history, like premature coronary artery disease, less than 55 men, less than 65 women, going through different generations in your family. That puts you at a very high risk for forming plaque really early on. So there is no study to say, oh, you have to have high cholesterol for 2 years, 5 years. So cardiologists like us that love preventing bad things from happening, as soon as we see the number is high, we're already talking to you about how to bring it down to the right levels.
Okay. Just one more on the fat intake. We have someone who has cardiac disease and osteoporosis. So should she be eating a full fat, low fat, or zero fat dairy? And the reason is that she was recommended to have full fat for her osteoporosis.
I'll say it because I just gave a talk about menopause and heart disease. So I don't think no fat is really an achievable thing, because we do need good fats for our body to metabolize. We do need good fats for, making cells, for repair and everything. So good fats are important. And there is no study to say that if you take a diet that's void of fats, that your risk for osteoporosis is low. No, I don't think there's no study like that. But menopausal women that are going through menopause and postmenopause, doing exercises with weights like density and building your density of the bone is important. And FDA has approved HRT, hormone replacement therapy, to help with preventing osteopenia from progressing to osteoporosis. So those are things to look into.
Okay, thank you. Yes, you had a question.
About those lines, because as you were saying, this topic is about cardiac illness in women. I think HRT is very, very important. And unfortunately, with the Women's Health Initiative results, those things were completely obliterated, right? So
absolutely, but what she's talking about is the Women's Health Initiative is a study that came out in the 90s, early 90s, I think 1990 is when, 2002. Okay, 2002 was when the Women's Health Initiative was published, and they looked at women that were older. So the average age of enrollment of women in the Women's Health Initiative was 62. So they had ended the study sooner because they saw more cardiac events in these women. That's when the use of HRT really went down. So we saw a downtrend with using HRT at that time. But even now, like from a cardiac perspective, like us as the ACC and AHA fellows, we don't recommend HRT as a prevention. We don't endorse that. But if you have symptoms, then absolutely understand your risk for heart disease, and based on that, we have specific recommendations to go on it. But whatever it is, to start on HRT sooner, within 10 years of being into menopause, or less than 65 is the preferred recommendation.
Okay, thank you. We got a question over here.
I did have a CT heart without contrast test, and it said I lined up at the 58th percentile by corresponding sex and age group. What does that mean?
It means that everybody below that, doesn't have that disease, basically. So, I mean, you're at kind of the average, let's say, a little bit above, but it's not that bad as being. So what it translates clinically, I'm going to say, if we see it's above the 75th percentile, that's our cue to go and treat you more aggressively. But you may have other risk factors that we have to treat. Okay.
Dr. Rodriguez, we have someone who has high LDL and triglycerides for about 5 years, and she's entering menopause. Should she be concerned to get her heart tested? She has no symptoms.
Yeah, I think so. If you have elevated cholesterol, I talked about family history. That's something that we also will inquire in our visit if she comes to see us.
Yeah.
But having high cholesterol and entering that stage of menopause, I think it's really important because our body as women changes, our metabolism changes a little bit. Cholesterol might go up, Nissi might confirm this too, and then we have to kind of recalibrate your risk a little bit to what's going on currently. I have a lot of perimenopausal and menopausal patients that their profile changes.
Okay, thank you. Yes, you had a question.
And I just want to add to that because everybody wants to get a test. That's why risk is so important to understand. That's why knowing your numbers is so important to understand. Like if your cholesterol is high, for primary prevention, even without any test, we want their LDL to be less than 100. Like straightforward, we don't need any other testing, right? But why we are doing the test, what we are going to do with the information is very important. We get some patients that don't want to take any medication but just want to know the risk. Then what are you going to do about the testing, right? So it's important to understand what testing to do. And I maybe down the line, calcium score will become a screening test for cardiac disease, possibly, because it's such an easy, very minimal radiation, no contrast test. But important to understand primary prevention just based on blood work.
How about advertisements for things like high flavanol cacao that supposedly clean arteries out? Is that just hooey?
I get a lot of questions about supplements. So we don't have a lot of studies to endorse these things, right? Somebody just said, oh, it helped a few patients, or they didn't actually do a randomized control trial to say if patients were on the cacao supplement and they check them 10 years later to reassess them. Nothing was done like that. So usually when you talk about supplements, it's good to take it with a pinch of salt, like understand, really, do you need that? Can you use your nutritional dietary things to supplement it? That's more important. There's very few supplements that have been tested in studies that we would recommend. But for things that have not been tested, it's on you.
My question over here is kind of multifaceted, but I was curious about if a patient or a person like myself who doesn't have any profile for any of the pre-existing conditions at all, right? How am I supposed to get into the doctor? And what if I were to have hypertrophic myopathy? If I have a pre-existing condition that I'm not aware of, how am I supposed to even get in to a doctor? Because I haven't been able to get into a doctor because I don't pose any risks at all for over a year. I was just curious about how I'm supposed to get help for myself. And I'm just advocating for myself, and I can't.
Sorry that I keep coming to the mic, but I will give my partners a chance. But that's why preventive encounters, we do, Christina and I actually do preventative encounters as a consult. So based on your insurance, you can ask your primary care to say, hey, I want to see a cardiologist to understand my risk and what I can do better. So we do see you there. But also, even otherwise, if you have conditions like hypertrophic cardiomyopathy, which is a very thickening of the muscle of the heart, there are symptoms that go with it too. There's EKG changes that go with it too. There's ultrasound is the basic test to do for it. So you don't have to wait to see a cardiologist to be diagnosed with certain conditions. They're found out initial status. That's why we encourage prevention, like the primary appointments are so important.
I will add that having a family history of sudden cardiac death, like somebody dying suddenly and you don't know why they died, that's kind of a good thing to mention to your physician so it can prompt further cardiovascular workup.
So I have a question about caffeine consumption from one of our virtual guests. She is 67 years old, was drinking dark roast in early morning, followed by regular coffee midday and possible decaf in the evening. Her PCP has restricted her to regular coffee only in the morning and decaf later in the day. Was her former pattern of caffeine consumption that dangerous? She does not add sugar or cream to coffee. She just loves coffee.
Well, I'll just comment on that from a heart rhythm perspective because people ask me this all the time. AFib, believe it or not, I covered up one of the slides that said caffeine because our data doesn't suggest that caffeine has a significant effect on AFib risk, actually. I will give the caveat that some patients can identify specific triggers for themselves, and in that case, obviously, avoiding those things is important. Also, avoiding excessive caffeine consumption. So I will ask people about their regular caffeine intake, like coffee, tea, and how, generally how much. Things like sports drinks, the, energy drinks, those things often have way too much caffeine, and in that case, then it becomes a risk factor for arrhythmia. That's specific to AFib. Supraventricular tachycardia is another heart rhythm that's different. Definitely caffeine can increase your risk of that. And so I would say the 2 cups of coffee a day within the moderate risk that my patients would be sort of allowed from arrhythmia perspective. That is, that's not to say anything about artery disease, which I will defer.
Thank you. Hold on. I just have a question over here. You've had your hand raised.
I had the Watchman procedure done last year and was told after I went through the whole thing that the little parachute didn't fit. And so they took it out, and now I'm Watchman free. Does that happen often?
It's rare, but it does happen. So when we do the procedure, we size everything very carefully because what we'd like to avoid is the device not to fit, because that would be a risk factor for dislodging, which would be a very serious complication, or for there to be a leak around the device, and then that would mean your stroke risk is still elevated. They have changed the devices over time, so they added a much larger Watchman device, and there are actually other types of devices out there now from different manufacturers. So depending on how long ago it was and what the specifics were, someone may want to potentially revisit that.
Hi. I have a question about lipoprotein A. Does the numbers ever come down? And I've heard there's a study maybe now that they're putting people in to see how you get those numbers down instead of people just dropping dead from it, which came from one of my doctors. I'm just curious.
Sure. I think a few caveats about that. Lipoprotein little a is a test that we do for genetic assessment. Basically, if it's elevated, it gives you a higher risk of having atherogenesis, which is the fancy word for plaque buildup in your arteries. And so we do it at least once in your lifetime so we can assess that risk and be more aggressive with what we can treat now, which is the LDL cholesterol. Now, their PCSK9 inhibitors have been seen to lower LP little a more than statins, but we don't have a direct treatment for LP little a, unfortunately. We're working on it, though. We are working on it. Ezetimibe, yeah, Zetia.
They went down from the 300s down to 218 this year. They hadn't tested it for 15 years. So it seems like it came down, and maybe it was the Zetia that helped do that.
Might be. There's also lab-to-lab differences because sometimes they measure it, I think, in nanograms or something, and other places they measure it differently. So if I were to test you again for I would go to that same lab. And I don't know if 15 years is a long time in between the two. So that might be why it's so different. Yeah.
Thank you. I've got a question over here.
I have a question. what is the impact of supplemental calcium on the hearts and the system, the coronary system? Because I heard there was a report that just came out that said it's not really a good thing.
If there is recommended, if you're truly osteopenic and you need the calcium, then then we said it's okay. Because what happens when you take the calcium supplement with the atherosclerosis already, it increases the calcium and it makes it, instead of making it more dense, it sort of makes it brittle, easier to break. So it was recommended previously that, if you have high cholesterol or plaque buildup already, like try to get natural calcium in your diet and whatnot. But we know that osteoporosis, osteopenia, the beginning stage of it, then I think right now we're saying that if you're truly medically recommended calcium, then it's okay. We'll just continue to monitor you. And if you're on a statin while taking a calcium, that's better because then it stabilizes it. It prevents it from making it brittle.
So I have extreme osteoporosis, I have genetic high cholesterol, but I am on a statin. So, and it also recommended a high dose of calcium.
Okay.
So, just
So-
start the studies that I'm
Yeah, that's okay. I think you can take it, and now that we have access to different studies, right? Say, for example, if you get a calcium score today, then you can repeat it in 2 years instead of 5 years later to see how much you've progressed without symptoms. Like if you have symptoms, that's different. Then there's other tests to understand. But at least for yourself to be at peace with what you're taking, because you need the calcium, yeah.
Hello, I have a question about calcium score and the soft plaque. So right now, people can get a cardiac CT and get their calcium score, and I'm a physician, so sometime I'll get that information. But now that you're saying that 0 definitely doesn't give you the whole picture, how do you talk to a woman who's in perimenopause and say this could possibly be some underlying GUI or cholesterol that I can't assess? And yes, I can go through their risk factors and counsel them, but I think unfortunately, because you can access these tests by yourselves, it gives women a false picture that when they see that big 0. So what other ways do you think I could address that?
That's really a very important point for me that I make for my patients when their calcium score is 0, that their risk is low. So coronary CTs are not a screening test. They're for patients that have intermediate or high risk for cardiovascular events, or they're symptomatic. Otherwise, even the insurance company won't approve them to get it. So if you just want to know your risk, it's really hard. So that's why, again, going back to basics, like aiming for an LDL less than 100 if they're non-diabetic for primary prevention and whatnot, that's more important. But I think it is hard because sometimes there's very high-risk patients. I see what you're saying, like that sometimes there's really high-risk patients and their cholesterol is high, they're not responding to statin, or, it's very hard. When they're really high-risk like that, I just aim to, try to bring their LDL to less than 75, whether they had a stent or not. Just being more aggressive with their presentation is more important because it's really, I think now it's easier. More insurance companies are approving coronary CTs for intermediate and higher risk patients. Previously, we had such a tough time getting it approved.
I will say that I appreciate that question. The calcium score of 0, I think I mentioned, is just the tip of the iceberg, but it does buy you some time of thinking, okay, I'm low risk enough, we can reassess my risk in a couple of years. And so I think that's the conversation that I like to have. Like, this is not an absolute thing. Like anything in medicine, we can't talk in absolutes. We lose if we do. Just being very clear with your patient, saying, okay, we did this can buy you some time. We know that you are at a lower risk than the rest of the population for having a heart attack with those words. But we'll repeat testing and see, monitor your risk factors as you go along. I think that's kind of the way I would handle it.
You had one slide that you mentioned SCAD, and I'm wondering if you can address, other than controlling high blood pressure, what can you do, and specifically on exercise?
So SCAD is spontaneous coronary artery dissection. It's when a membrane inside the wall of the blood vessel separates from the wall and creates a false lumen and closes the lumen, causing a heart attack. Most commonly seen in pregnant women or just around partum, like after delivery. Sometimes we see it in other patients too. For those patients, exercise, so depending on your symptoms, usually 6 months, right? We monitor you for 6 months for your symptoms. We can repeat a coronary CT scan to see if your SCAD has healed completely. If you have ongoing symptoms, we recommend you not to lift any weights or to be cautious with the exercise. And when you do start exercise, you do it at a very low impact exercises after the 6-month period of waiting, depending on your symptoms.
Dr. Rodriguez, while you're up there, one of our virtual guests has high cholesterol or high LDL cholesterol, history of heart murmurs, but she's under 30. Should she get screened by a woman's heart specialist?
Absolutely. I want to see every woman that has questions about their heart. So
okay, we heard it here.
Jokes apart, but
Yeah.
she should at least see her primary care because they should do a lipid panel annually, at least once a year for patients that are not on medications. And like I said, LDL less than 100 for primary prevention for anybody without any comorbid conditions. Aim for an LDL less than 100. So they should. But the caveat there is she's 30 years old. I don't know if she has children or she's planning to get pregnant, because then if you are, then you have to withhold statins for at least 3 months prior to pregnancy because it interferes with that.
I have a question about the calcium numbers. If someone had a calcium level of 468 and her cardiologist said, well, I won't worry about that unless it was 4,000, what would you be concerned? Yeah.
I think
Yeah,
for
should I
me,
find
anything over 300 is a high risk. So then it depends on your risks and how you're presenting and what we can do to manage you, whether we can just manage you medically or we need to send you for an angiogram to see what's going on. Because important to understand that even if you have significant plaque, okay, and if you have chest pain symptoms, if I were to treat you appropriately with medical therapy, and if your symptoms are controlled, your outcomes are similar to another patient with the high cholesterol plaque with a stent that was placed. So the outcomes are similar. So I can medically manage a patient with high risk as well, but treating them appropriately is important.
Okay, we have a virtual guest who has asking if you can have too low a blood pressure. Her blood pressure ranges from 110 over 70 to as low as 90 over 69, and she's 75 years old.
I think she's lucky if she's not symptomatic. I think low blood, anything less than 90 would be concerned, or anything less than 100 with symptoms would be concerning. There are some women women until menopause, majority may have low normal blood pressure, and the transition actually puts us into a hypertension range. But there are medications to help with patients with low blood pressure and symptoms so that they're not feeling dizzy or weak or mental fog and can't really have a good quality of life. So it depends on case-to-case basis.
While you're up there as well, we have another virtual guest who wants, what are recommendations so that they can be their best advocate if their heart symptoms are being dismissed by a primary care physician or someone in the emergency room?
Just tell them, am I having a heart attack? I'm afraid I'm going to die of a heart attack. Do I need to see a cardiologist?
Okay, my question is, when you go see the primary care doctor, I'm on atorvastatin. I take, right now they have me on 30 milligrams, and I'm down to 110, so she upped it to 30 to get it to go under 100 on my high LDL. I've been menopausal since 27 years old, and I'm currently 71. So I don't have any other real major symptoms of anything. I'm not on any other medication. But what can I do when I go back to see her in May, she's going to reevaluate my cholesterol. What can I say to her that would push her to set me up to get an approval to get complete cardiac testing to find out what's going on with the information that you gave us? Because it's never been presented to me. No one's ever even brought it up.
So you were 27?
I'm 71.
No, you were 27 when you were
When I had a
menopausal?
hysterectomy, I was 27.
Did they take out your ovaries too?
Everything is gone.
And were you on hormone replacement therapy?
I tried it and it did not agree with my system. It made me very crazy. So I couldn't use it, and I don't have any real problems. I have minor issues with dryness, but I manage that well, and I do not have painful relationships with my husband. Everything is fine, but I would like to get those cardiac tests done because cardiac problems do exist in my family.
Yeah.
But I've never had anyone say to me, "Oh, we need to do some cardiac tests on you to run and see what's going on," ever.
Yeah.
So what should be the proposal I bring to my doctor in May saying, I'd like to get certain tests done to evaluate my heart health?
Sure. Well, thank God you're in your 70s and doing well. Because premature menopause, less than 40 years, does increase your cardiovascular risk. And usually in patients that are in menopause less than 40 or 45 even, early menopause, should be on much higher dose of hormone replacement therapy that's physiologically replacing it. It's a medical treatment, not even like symptom correction or anything like that. And for you, you can just ask your doctor that you want to know what your calcium score is.
Okay. That would be the primary question?
Or you can say, hey, I want to know my risk and I see a cardiologist because I've learned that premature menopause causes heart disease early on if I was not on HRT. And you can know your risk. And if your insurance doesn't approve a calcium score, it's $180 spent really well to give us a lot of information.
Okay, thank you.
Okay, we have a question over here, please.
I was wondering if electrical issues with the heart, like the AFib or the like a level 1 heart block, is that considered hereditary?
Great question. So there are some electrical problems that are hereditary. There are some that go along with other heart disease. So if you think about the structure of the heart, the muscle and the electrical system interact. They're very intertwined. So muscle problems like cardiomyopathy, can result in electrical problems. Things like first-degree AV block is a type of physiologic heart rhythm. So remember I mentioned that the normal pacemaker of the heart's the top chamber, and then there's that kind of stoppage point, that gateway in the middle. That gateway can sometimes cause a delay that's normal, or it can sometimes have pathologic delays that are dangerous. And the way that appears on an EKG, basically what I look at all day, those are those signs and symptoms. Those little specific signs are the ones we can tell the benign types from the more serious kind. But to answer your question, are electrical problems all hereditary? They are sometimes hereditary. They're often not. A lot of the electrical problems I treat that result in things like heart block or something else called sinus node dysfunction. The reason I put in pacemakers, by and large, the largest reason is aging heart. It's just that the heart and the electrical system gets a little bit scarred over time. We always, anytime talking about AFib, other electrical problems, any of the other heart diseases, we're always looking for a secondary cause first. Like, is something else that I can fix causing this problem that I'm looking at? And then if it's not, then we kind of go through kind of the things we talked about, like AFib. If it's not caused by something else, then I'm treating the AFib electrically, for instance. So as far as things like heart block, I usually look for reasons, or oftentimes it's something simple as age.
Dr. Cuk, while you're there, one of our virtual guests, she can sometimes have an anxiety attack where the heart rate jumps from 80 beats per minute to 180. It will eventually go down, but she's wondering if whether or not she should get checked and concerned about that at all.
Great question. So oftentimes arrhythmias, things like AFib or other arrhythmias, supraventricular tachycardia or ventricular tachycardia, these can be, missed or often, attributed to things like anxiety because they come and go. And then when you come to the doctor and they don't catch it, well, then it must have been something as simple as anxiety. Well, if your heart rate is going that fast from time to time and you catch it, that's something concerning enough to go get more testing. Sometimes that testing shows a normal fast heart rhythm, which has its reasons and it has its treatments, or it can be an abnormal fast heart rhythm like an arrhythmia that we should go and take care of so that those symptoms don't recur.
Okay.
We have a question over here, I think.
Oh, yeah. Oh, my apologies. Sorry. In the front row as well. Hold on. We see you as well. Please.
If you've had an ablation, are you still at risk for a stroke?
Good question. So when I counsel patients, I always separate the two arms, stroke prevention and rhythm treatment, because all of our treatments historically have separated them and have suggested once you have AFib, you have an increased stroke risk. As time goes on and our data is getting better and our ablations are getting better, we're finding that being in normal rhythm really is better for stroke risk. We don't have specific numbers to that effect as far as clinical trials that I can present to patients, but we're getting more information about that as time goes on. But it's mainly the reason is when your heart has been in AFib, if it comes and goes, even if it's short, that top chamber of the heart can get weak. So you can have a stroke even in normal heart rhythm just because of the weakness that was caused by having AFib in the past. Sometimes if you have an ablation and you maintain normal rhythm for a long time and it never comes back, depending on your individual stroke risk, your doctor might say you're at lower risk, you could stop blood thinners. For my older patients, that's usually not the case because the age will add up to their stroke risk and they'll typically be benefited from the blood thinners long term. But long story short, being in normal rhythm is better for your heart function and will essentially result in lower stroke risk.
I was having chest pain, so I went to a cardiologist, had all the tests, and he said everything was fine, and I found out I had costochondritis. Is it? Yes. Yeah, and it's painful, but it's just your ribs. But I don't know if people know about that, because I didn't have anything wrong with my heart.
I think that's a common cause of chest pain, even though we don't think about it too much. It's part of our differential, especially kind of one of the questions that I asked is if you touch yourself and it hurts, it's reproducible, what Dr. Suppogu mentioned, then it might be just musculoskeletal rather than cardiac. Cardiac chest pain is also exacerbated when we exercise, usually. But the key is that kind of palpation that you can feel and you can reproduce your pain. That's more muscular than cardiac. Oh, that can be, yeah. Yeah, but we generally, when we evaluate chest pain, we always think about costochondritis as our differential. Actually, we're hoping it's costochondritis. We hope it is, because you can take NSAIDs and stuff like that to minimize the pain and inflammation of your muscles, basically. Yeah.
Dr. Rodriguez, while you're up there, how do PET scans help cardiac diagnosis?
Oh, they're great tests. So we mentioned a few stress tests. Nuclear stress tests, remember that word that Dr. Suppogu mentioned? We have two types, the PET scan and then the SPECT scan. And it's a really good and accurate test for diagnosing coronary artery disease. Very good for that.
I want to add it for microvascular disease. So PET scan is the gold standard non-invasive testing to diagnose microvascular disease because it helps us to understand the perfusion. We can calculate the amount of perfusion through the muscle of the heart. And PET scan, like Dr. Rodriguez mentioned, is so far more superior than the SPECT that we do because the radiation is lower and the resolution is higher. So it's definitely a better test to do, both for obstructive disease and for non-obstructive disease.
Okay. What about if someone has plaque? Can they reduce it with lifestyle modifications, or is it always going to be there?
I think they've done some regression analysis studies and whatnot on plaque, but once you have it, you can only stabilize it. It doesn't
Okay.
go away. It doesn't disappear completely. It gets lesser and lesser maybe, but I don't know if you had an established plaque if it goes away.
Okay. Okay, how about questions? It is, I can't believe this, 7:20. We've all been together 2 hours. It's been great, don't get me wrong, but I did want to just maybe close out for our speakers and just thank them. Let's give them all a round of applause. They really put a lot into this so that you're walking away with great information and really feeling empowered. And so they will be here a little bit if someone else has some questions afterwards. But thank you so much. And we also have another event coming up that you'll all receive a mailer on, and it will be at the end of April. I forget the date, but it's on lower GI distress. All the things we don't want to talk about with anyone will be presented on. I think it's the last Tuesday of April. Yes, I'm hearing a shake nod, so you will receive. Thank you. Fill out the surveys as well, because that's how we know what's interest to you. Okay, thanks everyone.